Video will narrate the stories of arrogant or stiff retina. We don't have any financial interest to disclose.
My audio is clear?
Yeah, yes. Perfect.
Main reason for an arrogant or stiff retina is proliferative vitreoretinopathy. Proliferative vitreoretinopathy complicates approximately 5 to 10% of all retinal detachment repairs. Typically, PVR occurs after primary retinal detachment repair. However, it can occasionally occur with long-standing primary detachment. PVR is responsible for 75% of all primary surgical failures. It remains a rock in the shoe of every vitreoretinal surgeon. Retinal detachment with PVR are sometimes like a brake-filled train, which is very, very difficult to react. This is a case of a recurrent retinal detachment with PVR changes. As the membranes are matured and formed, we can easily remove these membranes by forceps. Removal of membranes from posterior to anterior is always safer. Once we release the visible membrane, PFCL is given to see any residual traction. After removal of the residual traction, laser is done. The second case, here the posterior pole has PVR changes causing the puckering of the macula. Here the ILM peeling and the epiretinal membrane removal helps the retina to settle without puckering. This is a long-standing funnel RD with posterior membranes. Releasing the posterior napkin-like membrane with the help of a forceps. Once the membrane is released, the posterior pole is stabilized by PFC. Peripheral vitrectomy done to remove all the traction. After doing a good laser, direct exchange of PFCL silicon foil is performed. This is a case of recurrent inferior retinal detachment. Revision of relaxing retinectomy is done to release all the traction and settle the retina. This is a case of an old GRT with extensive anterior PVR changes. Patient had a complicated cataract surgery and was referred. After doing a core vitrectomy, PFCL is given to stabilize the posterior pole. Posterior membrane is released by forceps to unfold the retina. After dissecting the peripheral membranes, the retina is still very stiff due to anterior PVR changes. So, relaxing retinectomy is performed. While performing the relaxing retinectomy, yellowish mass was seen. Eventually, it was found out to be the dropped crystalline lens, which occurred due to a complicated cataract surgery. The dropped lens migrated through the giant retinal tear. The dropped lens is emulsified by fragmentome. 360-degree relaxing retinectomy was performed to reattach the stiff retina. Sometimes the membranes are invisible or there is invisible PVR changes. This traction eventually leads to subretinal air. We tried to take out the subretinal air through the retinotomy, but the underlying traction was not relieved. There was again subretinal air. So to relieve the traction, 360-degree encirclage was given by 42 band. After giving the belt buckle, the subretinal hair smoothly came out and the retina settled. So in extensive stiff retina, either a 360-degree encirclage or a relaxing retinectomy is necessary. Sometimes immature membranes causes a very stiff retina. After doing a meticulous peripheral dissection, thick subretinal fluid is drained through a nasal retinotomy. While the thick subretinal fluid came out of the retinotomy, a strange thing happened. In all quadrants, there was spontaneous tension retinotomies and the retina settled by its own. It might be due to atrophic and rigid retina. All the retinotomies were meticulously lasered. 360-degree encirclage might have prevented this kind of unusual tension retinopathy. So to conclude, as retinal surgeons, we should never ever give up. The challenge of dealing immature membranes or invisible PVR is still there. Doing a combined sterile buccal or relaxing retinectomy reduces the intraoperative surprises like subretinal hair or a spontaneous tension retinotomies and prevents postoperative maxillary formation. So, we retinal surgeons have to be the superhero and tame the beast in the form of arrogant retina by using enhanced surgical techniques. Thank you.
That's excellent, Dr. Annirudh. I think I will have a couple of questions. One from Dr. Mudit, please. He's our moderator of the session. Do you have any questions for Dr. Annirudh Maiti, sir?
Yeah, hi, Dr. Maiti. Great videos as always. But just a question for you and also for our esteemed panelists, Dr. L.A. Banker, sir, Dr. Malika Goyal and Dr. Mahesh. How commonly do you use a dye to sometimes change these membranes? Sometimes these membranes may be immature. Sometimes you see some subretinal membranes also. And using a brilliant blue sometimes makes the visualization of the membranes easier. So how commonly is it used in your practice when you see these complex cases?
Definitely, at times we need to use this, and another instrument what we sometimes use is a finesse loop. Sometimes the immature membranes we can take it out with a finesse loop. I think that helps in many cases where we are not very there is no mature membrane as such.
All right.
I agree with Annirudh. The other tool which I use a lot extensively is the Thanos diamond duster. I use it to gently scrape off all the membranes, even the tough membranes, or even sometimes the invisible membranes, as he showed in one of the cases. And it very nicely actually raises off the edges of the membranes. And then I just squirt in a little bit of IVTA, which actually stains the edges of the raised membranes. And then you can hold your end gripping forceps or a max grip to gently lift it off. So most of the times in all my PVR cases, I usually start my dissection with the Thanos forceps. But as he said, yes, the finesse loop also is very useful. You decrease the size of the loop to make it a stiff kind of a retinal pick-like thing. And then as gradually you are removing the membrane, you can increase the length of the loop, which makes it more flexible. And then you can slowly kind of, gently massage the retina in a very flexible manner with the entire loop and remove all the membranes.
That's a very useful tip, sir.
Yeah.
So do you have some comment, Dr. Mahesh, sir, please?
I already told the importance of belt buckle in especially inferior PVR has to be reiterated. Many people nowadays don't put belt buckle, but it can save us from extensive relaxing retinotomies. So I think the belt buckle has a role in these sort of cases.
Yeah. When we say mature membranes, like when you see a patient who's developing a redetachment with membranes, would you like to wait for some days to have the membranes mature and complete the, and stabilize? Would you put them on steroids for some days and then operate, or would you operate immediately? So some clarity on that.
I think we don't wait for the case, it might deteriorate further. We don't wait the mature to get mature, membranes to get mature. We have to deal with the immature membranes. That's my take.
Anybody else has any other thinking on this?
I think I agree with him. If there's a membrane, I think we should intervene immediately. But there are certain cases, and I've had quite a few cases where you filled in oil, and post-operatively you see a little bit of an inferior fluid or a shallow fluid, but there are no membranes. Then you can still wait. You can ask the patient to position, and most of the times the fluid gets absorbed within 10 days. So it's not that every residual fluid is a sign of intervention. But yes, I think formation of membranes, which is not going to be in an acute post-operative stage. The membranes are going to develop over a period of 2 to 3 weeks. And if you see these developing and, actually you can see the traction developing, then I think you should intervene immediately.
Yes, I think so too, sir. Because if you leave it around, then subsequently even the retina becomes intrinsically taut and contracted. And then even removal of the membranes may not then lead to, then you'll have to resort to a retinectomy over that area. So I think once you see membranes, it makes sense to intervene at that point of time rather than probably waiting.
And always with silicone oil removal, you can remove some other membrane maturing at that time.
Yeah. Personally, though, I feel that what from experience is that sometimes when you intervene a little early, the membranes do tend to form back because the PVR is still in a development stage. If you just wait for a couple of weeks, maybe with steroids, and then the membranes are thicker, easier to remove. But of course, under close follow-up, not allowing the case to deteriorate. But then your chances of recurrence reduce if you have allowed the PVR to reach a particular stage in its development.
That's wonderful. So can we have the next speaker, and that is Dr. Saumen Mandal, please?
There's one more point I'd like to make.
Sure,
when we are referred to a case with a complicated, cataract surgery, and the IOL has been put, but we don't see the IOL, we have to be careful. Like you showed, the nucleus lying under the retina. I've had finding the IOL under the macula.
Right.
So that is another thing we have to be careful about.
Yes.